This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here, and today we are diving into a topic that hits close to home for anyone who spends time in the tumor board or the Gamma Knife suite.
And I'm Dr. Alara. Today, we're looking at a fascinating new study from Breast Cancer Research and Treatment, published in 2026, titled A Phase 2 Study of Atezolizumab in Combination with Stereotactic Radiation for Patients with Triple-Negative Breast Cancer and Brain Metastases.
This is a tough clinical scenario, Alara. Triple-negative breast cancer, or TNBC, is essentially the triple threat we dread in neuro-oncology because it lacks the estrogen receptor, the progesterone receptor, and the HER2 expression. Without those targets, our systemic options have historically been very limited.
Exactly. And as the paper points out, TNBC accounts for about 15% of breast cancer cases, but the risk of distant recurrence and death within 5 years is significantly higher compared to other subtypes. From a neurosurgical perspective, the statistics are even more sobering. Between 25% and 46% of patients with metastatic TNBC will develop CNS metastases.
And once those brain metastases are diagnosed, the median overall survival has historically ranged from just 3 to 7 months. Even with our best CNS-directed local therapies, surgery, WBRT, or SRS, the outcomes have remained poor. That's why the premise of this study is so important. They were looking for synergy.
Right. The authors mentioned that preclinical models, specifically mouse models of breast cancer, suggested that radiation therapy might actually enhance the efficacy of immune checkpoint inhibitors, or ICIs. The idea is that RT and ICIs act synergistically to upregulate tumor-associated antigen MHC complexes and promote the infiltration of antigen-specific T cells.
It's that abscopal effect we often talk about in residence conferences. The hope is that by using SRS to treat the brain, we aren't just achieving local control, but we're also potentially reducing the accumulation of myeloid-derived suppressor cells and upregulating PD-L1 expression to help the systemic ICI, in this case atezolizumab, work better.
This was an open-label, single-arm Phase 2 study. They specifically targeted metastatic TNBC patients with brain metastases. The primary endpoint was progression-free survival, or PFS, but they used a very specific metric, the Response Assessment in Neuro-Oncology Brain Metastases, the RANO-BM bicompartmental model.
That's a key detail for our residents listening. In neuro-oncology, the bicompartmental model is crucial because it allows us to track what's happening in the brain separately from what's happening in the rest of the body. You can have a patient with a stable brain who is progressing systemically, or vice versa.
They also looked at the extracranial objective response rate, overall survival, and safety. They actually started with a safety run-in for dose-limiting toxicity, or DLT, after the first 6 patients were enrolled.
And let's get into the results, because this is where the reality of clinical trials in this population sets in.
It's a bit of a cautionary tale. 6 patients were enrolled in that safety run-in between May 2018 and October 2019. Now, the good news from a safety perspective is that no DLTs, no dose-limiting toxicities were observed. However, the study had to be closed early because of slow accrual.
Slow accrual is the nemesis of these trials, especially when patients are often too sick or have rapidly progressing disease that disqualifies them before they can even start. What did the treatment actually look like for those 6 patients?
All 6 patients received the stereotactic radiosurgery as planned. For the atezolizumab, the median was 2 cycles, though there was a range from 2 to 16 cycles. Regarding safety, 4 of the 6 participants, that's about 66%, experienced treatment-related adverse events, but thankfully they were all grade 2.
So it was feasible. We can safely combine SRS with atezolizumab in these patients without seeing a massive spike in neurotoxicity or systemic complications in this small sample. But Ilara, what did the efficacy look like?
This is the difficult part. The median bicompartmental PFS was only 1.3 months.
1.3 months. That's essentially the time it takes to get the first follow-up scan.
Exactly. It suggests that for most of these patients, the disease was moving faster than the treatment could take hold. The median overall survival was 9.7 months, which actually sits a bit higher than that historical 3 to 7 month range you mentioned earlier. Though with only 6 patients, we have to be very careful with that interpretation.
Was there any outlier? Anyone who did particularly well?
There was. One participant, about 16.7% of the cohort, achieved stable disease for 24 weeks or longer, according to RESIC 1.1 criteria. So there was at least one patient who saw a meaningful period of disease stability.
It's interesting. We see this often in immunotherapy trials, a tail on the curve, where most patients don't respond, but those who do can have a more durable response than we'd expect with traditional chemo. But a 1.3-month PFS really highlights the aggressive nature of TNBC brain mets.
The authors were very candid in their conclusions. They stated that while concurrent SRS with atezolizumab was feasible, the disease outcomes were poor. They explicitly called this a significant unmet medical need.
For our practicing neurosurgeons listening, how does this change our approach? Does it?
I think it reinforces that SRS remains a cornerstone for local control, but it also shows that synergy isn't a magic wand. The paper mentions that in melanoma and non-small cell lung cancer, the combination of SRS and ICIs like nivolumab or ipilimumab has shown improved survival and was well tolerated, but TNBC seems to be a different beast.
It goes back to the biology. The paper notes that in mouse models, RT upregulates MHC complexes and enhances T-cell infiltration. If we aren't seeing that translated into a longer PFS in humans with TNBC, we have to ask if the immune environment of a triple-negative brain metastasis is more immunosuppressive than, say, a melanoma metastasis.
And the abscopal effect they mentioned, the idea of seeing a response at distant sites, wasn't really observed here in a significant way, given the best response was stable disease in only one patient.
It's also worth noting the timing. The safety run-in ended in 2019, and the study was published in 2026. It takes a long time to get even this much data on such a specific, high-acuity population.
For the residents, I think the takeaway here is the importance of the bicompartmental RANO-BM. When you're looking at these papers, don't just look at PFS. Look at how they measured it. If they aren't looking at the CNS and the systemic compartment separately, they might be missing the full story.
Absolutely. If a patient's brain is clean but their liver is failing, the neurosurgeon might think the SRS was a success, but the patient is still losing the battle. This study tried to capture both.
Any final thoughts on the study's limitations?
Well, the obvious one is the N of 6. You can't make definitive clinical guidelines based on 6 patients. But in a rare or highly aggressive subset like this, even a small phase 2 safety run-in is valuable. It tells us that we can safely give these treatments together. We just haven't found the right key to unlock the immune response in TNBC yet.
It's a call to action for more basic science research into the TNBC microenvironment in the brain. The synergy is there in the mice. We just need to find out why it's stalled in the clinical setting.
Well put, Alara. To our listeners, this paper is a reminder that while the results aren't always what we hope for, every trial brings us closer to understanding these complex pathologies.
You can find the full study in the 2026 volume of Breast Cancer Research and Treatment.
Thanks for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. We'll see you next time.